Medical disclaimer: this video is produced for entertainment purposes only. I am a retired MD and PhD in biochemistry. I am not currently practicing medicine, and nothing in this series constitutes medical advice. All analysis is an intellectual exercise in clinical reasoning. No private medical records have been accessed. All individuals are presumed healthy unless proven otherwise. Viewer discretion is advised. Neurologists have a saying, "Watch them walk in." In a clinical setting, a patient's gait can tell a trained observer volumes about their nervous system. Before they say a single word, their movement can reveal what's happening inside. Today we're looking at public footage through a neurologist's eyes, and the picture is not reassuring. Segment 1. Gait analysis. Normal human gait involves heel strike, mid-stance, and push-off. It should be a smooth, rhythmic cycle with bilateral arm swing and an upright torso. What we observe in recent footage is something different. The shortened stride length, the forward flexed posture, a slight but consistent lean, the reduced arm swing on one or both sides, the apparent difficulty navigating inclines. These features, in a person of advanced age, constitute what neurologists call a Parkinsonian gait. Now, Parkinson's disease is the most famous cause, but it's not the only one. Vascular Parkinsonism produces almost identical findings. It is caused by multiple small strokes or ischemic lesions affecting the basal ganglia. It differs critically by affecting the lower body preferentially. That means gait and balance deteriorate first. While the hands may be spared the classic pill-rolling tremor we associate with idiopathic Parkinson's. This distinction matters. Vascular Parkinsonism does not respond to levodopa. It progresses stepwise, meaning each event creates a functional step down. It almost always co-occurs with cognitive impairment, because the same vessels feeding the basal ganglia also feed the frontal lobes. Beyond gait, neurologists listen, and what we hear in recent public appearances includes several clinically meaningful patterns. Verbal perseveration, the inappropriate repetition of words or concepts. The brain returns to the same phrase like a needle stuck on a record. Word-finding difficulty, pauses or substitutions when the exact word cannot be retrieved. This is called anomia, a hallmark of early cognitive decline. Phonemic paraphasia, the substitution of an incorrect but sound similar word, saying oranges when you meant origins. The brain confuses phonologically similar candidates during word retrieval. Then there's apraxia of speech, difficulty executing the motor plan. This results in stumbling, self-correction, and bizarre mispronunciations that the speaker seems unaware of. These are not normal aging findings. They are clinical signs of a process affecting language-dominant hemisphere networks and frontal executive systems. Placing these findings in context, the differential diagnosis from a movement disorder specialist's perspective would include vascular cognitive impairment with lower body Parkinsonism. My leading hypothesis, given the cardiovascular risk factors established in Episode 1. Normal pressure hydrocephalus, characterized by the classic triad of gait disturbance, cognitive impairment, and urinary incontinence. Or a mixed picture, Alzheimer's disease with vascular contribution, now recognized as the most common form of dementia in elderly patients. Vascular etiology is compelling because of its mechanistic link to the heart disease, edema, and hypertension established earlier. These are the upstream causes that damage cerebral vasculature over decades. Here is what to watch for in coming months. Increasing frequency of public stumbling or near falls. Progressive shortening of public speaking engagements. Increasing use of teleprompter even for simple remarks. Evidence of spatial disorientation, confusion about surroundings. Any frank fall in public would represent a significant neurological event. These are the quiet signs of a nervous system in decline. They are observable. They are measurable. And in a man with nuclear codes, they demand our attention. In Episode 3, we move to sleep architecture, energy regulation, and what a metabolic specialist would say about the paradox of midnight tweets. Learn more about this series and other stories at unbedsidemanners.com. This has been an exercise in clinical reasoning.